Hi gang, let's go ahead and talk about syphilis and a little bit of serology about how we can actually help to diagnose syphilis. So stay tuned. All right, so the organism that causes syphilis is Treponema pallidum. It is a spirochete that can actually penetrate the skin, much like Leptospira can. The spirochetes are difficult to grow on traditional micromedia. So it's often diagnosed immunochemically in the serology laboratory. Some people can be immune and other people progress to the latent stages. The diagnosis can be made by detecting antibodies in the patient samples. Specific antibodies are detected in a TPPA, the Treponema pallidum particle agglutination test, or we can look for antibodies that are screening, or we can look for a biological nonspecific reagent, which is a nonspecific test for syphilis, and this is called the RPR test, or rapid plasma reagent test. It is a nonspecific reagent that can be elevated in things like syphilis, hepatitis, mononucleosis, and things like that. So syphilis is caused by Treponema pallidum, and we can look for syphilis by screening, doing the RPR test, or by a confirmatory test known as TPPA. There's also a fluorescent antibody test for Treponema pallidum as well. Now, syphilis is considered a primary sexually transmitted disease, and there are some social issues that actually exacerbates the problem, and that would be things like poverty, lack of health care, lack of education, and there are 12 million people infected with syphilis every year. Just when you thought it was going down, it's actually still pretty high, 12 million people that are infected every year. It is transmitted by sexual intercourse, oral lesions, kissing, and also refrigerated blood products for up to 72 hours after collecting. Sharing a bed with an infected person, usually children sharing a bed with adult guardians, and finally syphilis can cross the placenta. There are 4 stages of syphilis, and these stages are called the primary stage, the secondary stage, the latent stage, and the tertiary stage. In primary syphilis, this is a stage that lasts for about 1 to 5 weeks. There is a sore known as a chancre present on our patients. It is contagious, and it usually appears about 10 to 60 days after contact with an infected person. The organism can penetrate the skin during this time, and you will see spirochetes in the chancres or the sores of the host, or you might see the spirochetes in their blood. The way that we diagnose primary syphilis is by doing a dark field exam, and we use a dark field microscope to look for the fluorescing spirochetes in the chancre. The second stage of syphilis is known as secondary syphilis. This develops about 6 to 8 weeks after contact with an infected person. In this stage, the chancre disappears and lesions start to develop in the eyes, joints, and the central nervous system. There's a rash that starts to appear on the palms and feet during secondary syphilis. It is diagnosed with serum antibodies. Usually we are not doing the VDRL spinal fluid test, but instead we can diagnose secondary syphilis by doing the screening test known as the RPR or a confirmatory test known as the TPPA. In latent syphilis, this develops about 1 to 2 years later. It may be actually asymptomatic in this state and is generally not contagious during this stage. It's usually diagnosed or usually not diagnosed during this time because, like I said, our patients are usually asymptomatic. We can test for serum antibodies, however, in the latent stage. Tertiary syphilis is also known as neurosyphilis. This can develop 3 to 30 years later. In fact, 50% of patients go into this stage. There are serious complications during this time, and there can be central nervous system disease, heart disease, and blindness. Although sometimes you can be asymptomatic in this stage of the disease. We can detect antibodies in serum and usually the spinal fluid. So here we could do what's known as the VDRL test, which is Venereal Disease Research Laboratory test, where we're looking for antibodies in spinal fluid. Here you will have an increase of lymphocytes in the spinal fluid, and you'll have very increased spinal fluid protein. Now, if we're looking for syphilis in our patient, again, we can do a nonspecific antibody test where we're looking for nonspecific reagent. And again, this is seen in either the RPR test or the VDRL test, or we can look for specific antibodies, which are noted in the TPPA test, treponema pallidum particle agglutination test, or a test known as the FTA antibody test, which is the fluorescent antibody test for treponema pallidum. So again, to diagnose cases of syphilis, there's a couple different tests that we can do depending on what stage of the disease our patient is in. So we can do dark field microscopy. That is usually a test done for primary syphilis. You might actually get false negatives if they're being treated with any kind of anti-spirochete drugs. We can look at the chancre scrapings, and they're going to be bright-looking spirochetes on a dark background. We can do direct and indirect fluorescent antibody testing. And again, the direct fluorescent antibody testing is performed on the lesion exudate. We can do rapid plasma reagent, which is the RPR test, which is a screening test where we're screening for syphilis in the serum. And we can do the VDRL test, which is an antibody test or a screening test in cerebral spinal fluid. We can do TPPA, which is treponema pallidum particle agglutination, where we have gelatin particles that are sensitized with treponema pallidum antigen. We can do DNA probing, or PCR, which is confirmed by Southern blot. And then finally, we can do EIA or ELISA tests that look for treponema pallidum antibody. And they can be 100% sensitive in all phases of syphilis. Now, Southern blot, just to remind you, is when we're looking for DNA fragment detection by probe hybridization. Again, we can do dark field microscopy to help diagnose primary syphilis. It is for the diagnosis of syphilis when the patient is symptomatic. It's not very sensitive, this test. It does require about 100,000 organisms per mil in order to see it microscopically. And it does require a dark field microscope with very specialized techs. The spirochetes appear bright on a dark background microscopically when observed from the chancre scrapings. Another way that syphilis can be diagnosed is through fluorescent antibody testing. A direct diagnostic method using fluorescent labeled antibody conjugate to treponema pallidum organism is the direct method. An indirect method for fluorescent antibody testing is where we use treponema pallidum with the second labeled anti-immunoglobulin antibody. The RPR test, or rapid plasma reagent test, is the most widely used non-treponemal serological procedure. It is a screening test that can actually be positive in other diseases besides syphilis. Here we are screening for non-specific reagent to the patient sample, but this can be elevated, like I said, in other diseases like infectious mononucleosis, malaria, hepatitis, and lupus, and this is called biological false positives. An indirect or passive agglutination test using antigen-coated charcoal particles is the rapid plasma reagent test. The antigen is a mixture of beef heart and charcoal known as cardiolipin lecithin cholesterol. That is the antigen in this test, cardiolipin lecithin cholesterol, and the antibody is nonspecific reagent. Together we look for passive agglutination where the charcoal particle in patient serum have agglutination. So here we have an image of the RPR test. We have a control card on the left and then a patient dilution of their serum on the right. What we have here is antigen, which is charcoal attached to the antigen, plus patient serum. We mix the sample and we rotate it at 100 RPMs for 8 minutes, and we look for agglutinins. We report these results as either reactive, weak reactive, or non-reactive. And again, they're not reported as positive or negative because these are just screening tests. So we report them as either reactive, weak reactive, or non-reactive. And then in the case of the titer there on the right, we would report out the last detectable antibody, which in this case looks like it would be 1 to 128. And we always report the reciprocal of that. So we would report the titer for RPR as 128. You can see 256 and 512, they're both smooth and we can't see any agglutinins in those wells. The VDRL test is an acronym that stands for Venereal Disease Research Laboratory Test, and here we are screening the spinal fluid for neurosyphilis. The samples must be inactivated or deactivated from complement, okay? And we do that by heating at 56 degrees for 30 minutes. The samples can be serum, but generally it is cerebrospinal fluid. The antigen here is cardiolipin, and that is dissolved in ethanol and buffered saline. The antibody we are looking for in the patient is the same as the RPR. We're looking for nonspecific reagent. Okay? Latex particles are coated with the antigen, and we look for flocculation. And flocculation is similar to agglutination, only it looks a little bit more feathery and less granular. This is called an indirect or a passive agglutination methodology. Okay? You can get false negatives on this if your patient is being treated with anti-spirochete drugs. Biological false positives are when you have a reaction in the serum on the screening test that is from the presence of an antibody not specific to the antigen used in the test. Biological, of course, means that it's caused from another living thing or disease association. So you can have biological false positives on your RPR test or your VDRL test due to such things as autoimmune diseases like systemic lupus erythematosus or rheumatoid arthritis. You can also have rheumatic fever, viral hepatitis and mononucleosis, acute bacterial or protozoan infections like leprosy or malaria. Those can also cause biological false positives for your screening tests like RPR and VDRL. Okay? Biological false positives will not affect confirmatory tests like your TPPA. So the treponema pallidum particle agglutination test is a confirmatory test for syphilis. It's semi-quantitative particle agglutination assay where we have gelatin particles that are sensitized with treponema pallidum. The antibody we look for in patient serum is anti-treponema pallidum. This is considered an indirect or passive agglutination procedure. So let's take a look at what the TPPA test looks like on the 96 well plates. So here is a picture of the TPPA test, and what we've done here is we have made serial dilutions in each row of our control and our patients, okay? So every row indicates either a patient or a control. A tight button that's observable indicates a negative test, while a flat mat indicates a positive test. So if you take a look at that first row, you can see that our first row, our first column in the first row is a little dot, and that little button indicates a negative test because here we are using non-sensitized particles. Okay? If you take a look at the fourth column in the first row, you can see that you have a flat mat, and that would be a titer of 80. Okay? And that would be an indication of a positive TPPA test. In DNA probes, we're not looking for an antibody. Instead, we're looking for any kind of molecular material that's been harvested, and we can match it to treponemal DNA. It's a very expensive form of testing, but it's very specific to treponema pallidum. In enzyme-linked immunosorbent assay, we are looking for IgM or IgG antibodies. Generally, the ELISA method looks for IgG antibodies that have crossed the placenta and have infected the newborn, leading to congenital syphilis. So most of the time, ELISA is used to screen newborns for congenital syphilis. So when we have a patient suspected of having syphilis, the first test that we're going to do is the screening test known as the RPR. The first thing we want to do is calibrate our needle and make sure that our blunt needle dispenses 60 drops per mil of antigen. So we always want to calibrate that needle by holding it in a vertical position. Then we attach that needle once it's been calibrated and quality control has been performed on it to our antigen. Okay? We want to set our mechanical rotator to 100 RPMs, and we should do quality control on our mechanical rotator to make sure that it actually is rotating at 100 RPMs. Okay? We have controls that we need to run. We either rehydrate a control card, or if we use a different vendor, we have controls that come lyophilized, and we have to dilute those up. And then the procedure is that we are going to take 50 microliters of serum and add it to each circle, spread that serum out, and then we're going to add a drop of well-mixed charcoal antigen. That's the antigen that has cardiolipin, lecithin, cholesterol. And then we don't mix it again. Instead, we put it on a rotator, and we set that rotator for 8 minutes. At the end of our 8 minutes, we're going to use an agglutination light or an agglutination viewer, and we're going to rock that card while it's still wet forward and backwards. And we're going to look for agglutinins. Those agglutinins will be very large in the case of a reactive test. They will be small with a cloudy background in a weak reactive test, and you'll have a completely cloudy background with no agglutinins in a non-reactive test. Okay, that's the qualitative procedure. That just tells you whether or not you have a positive or negative RPR, or reactive or non-reactive RPR. In a quantitative procedure, you can actually make serial dilutions of your patient's serum. The TPPA test is the confirmatory test for syphilis, and this procedure is a little bit more difficult. Okay, essentially what we're going to do is we're going to take a U-bottom microtiter plate that has 96 wells, and every row is going to be either a control or a patient. Okay, so what we want to do is in our first column we add 100 microliters of sample diluent into well 1 in the first column. Then in the second column we add 25 microliters of sample diluent in wells 2 through 4. Then we add 25 microliters of patient sample or control to well 1, and then we make serial dilutions, transferring 25 microliters from the first well to the second well, from the second well to the third well, to the third well to the fourth well, etc., all the way through the 12th well. Okay? And then we allow it to sit for 2 hours at room temperature. At the end of 2 hours, we look for either flat mats or buttons. Buttons are considered non-reactive wells, while a flat mat is considered a positive well. And so we can actually figure out the titer by looking for the last positive well. Our last detectable antibody is our positive titer. Now, there are a couple of ways to interpret our test for syphilis. If we have a non-reactive test, it usually means that our patient doesn't have the disease. However, it could mean that they're just not making antibodies yet. It could mean that they have gotten some sort of treatment and now their test is non-reactive. Could be that there was an inferior technique used by the MLT, or it could mean the patient has consumed alcohol. Those are all things that give you non-reactive tests. We can have a weakly reactive test, and that could mean that you have inferior technique used by the tech, or our patient could be in the very early stages of the infection, or you could have a biological false positive such as mono or lupus, rheumatoid arthritis. Okay? If we have a reactive test, it probably means that our patient has syphilis. Then what we'd want to do is go on and do the TPPA test or the fluorescent antibody test. It could mean we have a biological false positive, or it could mean inferior technique. So anytime you're performing these tests for syphilis, you do want to make sure that you do quality control and that you critically think as to interpreting the test results.